Chinsky. And one thing I can assure you is that this lecture is not near as entertaining as some offerings you might find on YouTube about the same subject. There is a lot of information, and some of it is, dry and a bit intense. Pay attention to the symptoms, diagnostic criteria, and the classes of drugs used to treat schizophrenia. There is a brief video here that's a good explanation of schizophrenia. Schizophrenia comes from the Greek words schizo for splitting and phreno for mind. Schizophrenia is not a split personality. Rather, it is a disorder of brain function that affects a person's ability to think clearly, make decisions, manage emotions, and relate to others. Schizophrenia is a complex, long-term illness. It affects between 0.25 and 0.6% of U.S. adults. In other words, between 2.5 to 6 per 1,000 people are affected. The World Health Organization lists schizophrenia as one of the top 15 illnesses. About 1% of the world population is affected. The onset of schizophrenia is typically late teens to early 20s for men and late 20s to early 30s for women. It's uncommon for a person to be diagnosed with schizophrenia before age 12 or after age 40. Causes of schizophrenia are thought to be a combination of genetics, problems with neurotransmitters such as dopamine, glutamate, GABA-aminobutyric acid or GABA, and acetylcholine, and the environment. Identified risk factors include immigration, living in an urban area, adverse childhood events, also known as ACEs, obstetrical complication, late winter or early spring birth may be related to influenza virus during neural development, prenatal maternal stress, and advanced paternal age. There is a high rate of co-occurrence with depressive disorders, anxiety, PTSD, obsessive-compulsive disorder, and substance use and abuse. The course of the disease is variable. About a third of people with schizophrenia respond well to treatment and live out normal lives. Another third wax and wane between health and exacerbations, and another third do poorly. Schizophrenia damages the brain. The lifespan of a person with schizophrenia is reduced by about 20 years. The suicide rate among those with schizophrenia is about 5%. Words about psychosis. Psychosis is the feeling that a person has lost contact with reality. A period of psychosis is called a psychotic episode. Psychosis can be a symptom of other psychiatrics such as bipolar disorder, major depressive disorder, schizoaffective disorder, schizophreniform disorder, and delusional disorders. Other causes of psychosis include traumatic brain injury and neurodegenerative conditions such as Alzheimer's disease and Parkinson's disease. Temporary psychosis can occur with prolonged sleep deprivation, traumatic events, periods of extreme stress, prescription medications, hallucinogens. When the events are over or the drugs have washed out, the psychosis clears. Psychosis can be caused by medications such as steroids, opioids, ibuprofen, anti-Parkinsonian, beta blockers, and substance use and withdrawal. I once met a woman who was hospitalized for psychosis who became psychotic after smoking synthetic marijuana. The symptoms of schizophrenia are categorized as positive, negative, cognitive impairments, and affective disturbances. Positive symptoms point to psychosis. Positive means that a quality or behavior presents that is not seen in normal people. This includes hallucinations, delusions, disorganized speech, and abnormal movement. Negative symptoms are missing qualities. The lack of normal characteristics or what you would expect to see in normal people, such as movements, eye contact, and facial expressions. Cognitive impairments refer to the ability to function in daily life, such as learning, memory, and decision-making. Affective disturbances are difficulties with mood and affect that can be detected before, during, or after a psychotic episode. Think of mood as a continuum from severely depressed all the way through to manic at the other end, with normal affect in the middle. Positive symptoms are added qualities. These are things that we don't see in normal people. There are 4 categories: hallucinations, delusions, disorganization of speech and thought, and abnormal motor behavior. Hallucinations are false perceptions, such as seeing things or hearing things that aren't there. About 80% of people with hallucinations report auditory hallucinations. Delusions are false beliefs with no supporting evidence. Usually, someone points this out to the person, but they won't change their mind because they are convinced of what they are thinking is true. They may be paranoid. That means they may believe that they're being poisoned, or that the FBI is following them, or that they're being controlled from the television set. They may have delusions of grandeur. They may feel wildly successful or wealthy, or claim they have supernatural powers. There's erotodelusions, which are about thinking that someone is in love with them. Disorganization of speech and thought makes it very difficult to follow a person's thinking. Speech is often incoherent, or what we call a word salad, which is a jumble of words and ideas all mixed together. The bus nose run trick is an example. Other speech problems include tangentiality, or going off on a tangent, getting off topic without answering questions appropriately. Circumstantiality, which is answering questions in a roundabout way without really ever coming to the point. Derailment, switching topics without logic sequence, just from one to the next. And neologisms, which is making up words or making new words. Abnormal thoughts patterns may include being inappropriately dressed, say in multiple layers on a summer day. Abnormal motor behavior is a little different. Often the person may have catatonia. This is an abnormal movement, or it can be a lack of movement. A couple of examples. Catatonia can include agitation, and this is not agitation from something that's happening to them. This is more of an agitation within. So rather than being agitated by something, they're just agitated. Another example is catalepsy, which is holding the position they're placed in, just like a posed doll, and they stay there until they're posed in another position. Echolalia, which is echoing the sounds around them, or echopraxia, which is mirroring someone else's movements. There are other forms of catatonia, which include not reacting, sitting in a position that would be completely uncomfortable for anybody else for hours and hours at a time. Negative symptoms are the absence or the loss of normal processes, what we see in normal people, such as emotions and interest. They can be referred to as the 4 or 5 A's, depending on which text you're looking at. I think our text has 4. They include affect. It's either blunted or flat emotional expression, no reactivity at all, or perhaps there's inappropriate reactions such as laughing. The second A is alogia, poverty of speech or diminished speech. They may give one-word answers to questions if they answer at all. The next A is asociality and anhedonia. Asociality is a decrease in social activities, a failure to engage with peers, and anhedonia is the lack of pleasure. They're put together here. The last one is avolition or apathy, and that is a lack of motivation, reduced sense of will, or not initiating any purposeful activity such as grooming, hygiene. There may be anergy, which is absence of any response. A third set of positive symptoms are cognitive impairments. These are good predictors of day-to-day functioning, such as the ability to keep a job or live independently, and some of these may be subtle. Poor executive functioning, it means that they have difficulty making good decisions or making decisions at all. They may have concrete thoughts. Things are either black or they're white. They're one way or another. They can't think in the abstract. Diminished processing speed means that their ability to take in information and make sense of it is slowed. They may have difficulty focusing or maintaining attention. They may have problems with verbal and visual learning and memory. It makes it very difficult to learn a new task. They may have poor verbal comprehension. They may not really be able to process or comprehend what someone is telling them. And they have impaired social cognition. The last of the positive symptoms is affective disturbances. Again, affect has to do with mood. This is when they exhibit poor self-esteem. There's often depression and anxiety, and they are at increased risk of suicide. The onset of symptoms may be either abrupt or insidious. That means slow and not really noticed at first, kind of like diabetes and hypertension, where you don't know you've got them until there's a problem. There are phases that have been identified. There's a prodromal phase where the person may become withdrawn and isolated. This is similar in depression and anxiety disorders. There's an active phase where the symptoms are severe. They have delusions, hallucinations, disorganized speech and behavior, or they may be catatonic. Followed by a residual phase or a return to baseline or back to their withdrawn and isolated place. And then they cycle into an active stage again. For a care provider, you as the FNP will likely be managing the patient for medical problems and for monitoring the side effects of antipsychotics. Additionally, we watch for symptoms, changes in behavior that may signal a prodromal period or a cycling of the symptoms. A patient that is severely psychotic is typically sent to the ER for management. When a patient presents to your clinic with changes in behavior, the focus of the history is going to be on symptoms and substances. What has changed? The focus of the physical exam is the mental status and the neurological exam. Differentials include substance use and withdrawal, medication use, anything changed there, medical problems, what's going on physically with the patient, other psychiatric disorders, what other co-diagnoses do they have, what could be causing these symptoms. So depending on the history and your physical exam, the FNP may order a CBC with a differential, looking for infection, looking for anemia, electrolytes, renal, liver, thyroid panels, looking for any changes there. Pregnancy, if this is a female of childbearing age, a UA, and a toxicology screen. Especially in our geriatric patients, a change in mental status may signal a UTI rather than an actual psychotic event. These are the diagnostic criteria for schizophrenia. You have to have 2 or more of the following symptoms that have been present for a significant portion of the time during 1 month or less if successfully treated. Of the 2, one of them has to be either hallucinations, delusions, or disorganized speech, bizarre behavior. The others can be grossly disorganized or catatonic behavior, which is the 4th positive symptom, and a negative symptom. Also, there has to be significant functional decline in areas like work and relationships, which covers the affective and cognitive symptoms. Continuous signs must persist for at least 6 months, including at least 1 month of active phase symptoms, which might be less if treated. One of the easier ways to remember this is HDSB network, where HDSB is hallucinations, delusions, speech behavior, and network is your negative symptom. The other part of that is 2, 4, 6, 2 symptoms present for 6 months, and that's about the easiest we can make this. The symptoms can be prodromal or residual or active phase. You have to exclude the depressive, bipolar, or schizoaffective with psychotic features, and you have to exclude substance abuse. The goal of management of schizophrenia is to reduce or eliminate symptoms, improve their functionality, and maximize their quality of life. This is done through early intervention, shared decision-making, adherence to a treatment plan, and managing comorbid conditions. Pharmacological management of psychosis requires antipsychotic medications. These medications are separated into first and second generation. The first generation drugs were developed first. The first generation or typical antipsychotics target the neurotransmitter dopamine. They work well, but they cause anticholinergic side effects. Think of drying, dry mouth, dry eyes, orthostatic hypotension, difficulty urinating. There's a high risk also of extrapyramidal side effects. These are unwanted movements which tend to occur after using the drug for an extended period of time. Second generation antipsychotics are also called atypical antipsychotics. They target dopamine and serotonin neurotransmitters. Second generation atypical antipsychotics are the first line drugs for treating first episodes of psychosis. There is a risk of developing extrapyramidal side effects, but it is less than with the first generation antipsychotics. The biggest risk with the second generation atypical antipsychotics is developing metabolic side effects such as weight gain, hyperlipidemia, elevated glucose. Think metabolic syndrome. All antipsychotics are included in the Beers criteria for geriatric patients because there's concern for sedation, orthostatic hypotension, and falls. The second generation antipsychotics, the atypical antipsychotics, are safer for geriatrics, but all of them have a black box warning for death and cerebral vascular events in patients with a coexisting diagnosis of dementia. Typical or first generation antipsychotics end in ZINE except for Haldol and L'Occitane. These drugs work by blocking dopamine D2 receptors. Antipsychotics are most helpful at reducing the positive symptoms. Remember, delusions, hallucinations, those behaviors that we don't usually see in people. They're less effective in managing the negative symptoms. Side effects are increased risk of extrapyramidal side effects and anticholinergic side effects. All first generation antipsychotics have a black box warning for using antipsychotic medications to treat dementia in older patients. Elderly patients with dementia or related psychosis treated with antipsychotic meds are at an increased risk of death from QT prolongation and from extrapyramidal side effects. Another thing to remember is that first-generation antipsychotics typically undergo hepatic metabolism, and they may interact with other drugs that affect the CYP or CYP metabolism. So keep that in mind. When you're working with these patients, you get a baseline EKG because of the risk for prolonged QT interval. The second generation antipsychotics or atypical antipsychotics end in either DONE or PINE. There are a couple that end in azole. These are very effective in treating symptoms of psychosis and are considered first line in treating a first episode of psychosis because they have a reduced risk of motor side effects or extrapyramidal side effects. Now, there is a risk for EPS, but the biggest risk is for metabolic syndrome. These atypical antipsychotics are used to manage many disorders, including bipolar, major depression, anything that may have a psychosis component. As the primary care provider, you will be monitoring someone that is taking second generation atypical antipsychotics for weight gain, increased lipids, and increased fasting glucose. It's important to measure their waist circumference. They can develop metabolic syndrome without close monitoring. For geriatric considerations, use these second generations cautiously in older people. While they are appropriate for treating psychosis and severe agitation, they need to be started low and titrated slowly to the lowest effective dose. These are included in the Beers criteria for concern for sedation, falls, and orthostatic hypotension. I don't think I can say that too many times. And the black box warning, all second generation antipsychotics have a black box warning for elderly patients with dementia-related psychosis that are treated. They are at an increased risk for death. This slide may help you remember the first generation and the second generation atypical antipsychotics. It's a nice little breakdown of the lists of each, the major mechanisms of action, and the side effects. Extrapyramidal side effects are involuntary movements of the muscles the person cannot control, and they can be debilitating. They are further subdivided into reversible and not reversible. Under reversible are akathisias, which is restlessness, pacing. Dystonias are involuntary muscle contractions. Think about spasms. They can occur in the voice and cause hoarseness. Pseudo-Parkinsonism, pill rolling, tremors, rigidity. And then the not reversible one is tardive dyskinesia, or TD. These are involuntary movements of the face, such as lip smacking or grimacing. The primary care provider, family nurse practitioner, needs to monitor patients who take antipsychotic medications for the development of extrapyramidal symptoms. Very simple to have the patient fill out the AIMS, or abnormal involuntary muscle scale, while they're in the waiting room to assess any level of these dyskinesias. If EPS develops and the person is taking a first-generation antipsychotic, they should be switched to a second generation. We want to stop these as soon as we recognize that the EPS has developed. Anticholinergic medications may help. Some anti-Parkinsonism medicines may help as well. All of these medications have their own side effects. Tardive dyskinesia occurs after long use of antipsychotic medications. The goal is to prevent, and that happens by starting with a second-generation antipsychotic, in which the chances of developing EPS are less. Patients who have TD may need to take anticholinergics and antiparkinsonians to help them control their symptoms, and newer drugs are being developed. It takes a team to manage a complex psychiatric disorder. Patients, family, and caregivers need information about the disorder, progression, and treatment. In some communities, an assertive community treatment program, or ACT, is available and provides services to individuals in the community who have severe and persistent mental illnesses, particularly schizophrenia spectrum disorders and bipolar disorders. Those types of disorders typically have psychosis.